So I'm going to ask Penny to answer one of those questions first, and then we can kind of move it around amongst ourselves. So we had questions about terms. Do we need a glossary of terms? Assessing client readiness, and how do we select from the buffet?
Completely agree with table 2. We do need a glossary. It's really confusing. I think we might have overemphasised the need to define health coaching this morning. It really is important that people know what we're talking about. We're very, very clear. We hope we might produce a terminology. If we don't do it, then Muir Gray is also working on one, so someone needs to do it, definitely. How do we know whether patients are ready for change? Very good question. I use my skills in health coaching in my consultation with patients when I feel I'm not getting somewhere, or whether, I just sort of adapt my normal consultation and throw in a bit of, on a scale of 0 to 10, how motivated do you feel, or could you imagine yourself in 6 months' time looking back, what would you have done, or, actually I need to just sit back and listen a bit more here, and is challenge acceptable? So I use it in my consultations, and I just see how it lands. So that's one way of using it. If it doesn't go down very well, then you sort of to back off and try another approach. Normally it goes down very well. In terms of a coaching surgery and selecting patients for we trained our nurses up, and we were actually giving them an hour long. We gave the patients a sort of short questionnaire, which is, would you be interested in a different sort of approach? Do you want to change? And we would scale up on a scale of 0 to 10, are you interested in things that you can do to change how you manage your own condition? And sort of selected them that way, or they selected themselves that way. That may not be the right approach, and I'm sure that there's probably a more scientific method through risk stratification in selecting patients. But I also know that it's not for everybody, and not all patients want to have a coaching type conversation. Some people just want to be told what to do. So I think in answer to that question, it's a bit of trial and error, and it's probably also a slightly more scientific approach than we have at the moment.
Thank you. Who else would like to pick up one or more of those points? Yeah.
So the readiness question first. The trans-theoretical model and the stages of readiness to change. Is anyone familiar with that particular model? So there is, in fact, a well-established, well-defined model with hundreds, if not thousands, of studies of interventions tailored for stages of readiness. And John Norcross's new book, Changeology, really brings home that when you're in pre-contemplation or denial, what the conversation there is mostly about empathy without any expectation. And then maybe finding some area of their life, if you're willing to go outside the box of health behaviors. In my experience, people in pre-contemplation about health behaviors are in contemplation and more interested in another area. And often that's the area that will free up, like starting with a smoker who has a confidence of quitting smoking of a 2 out of 10, usually you're better off to help them come up with some other behavior which might relieve the stress that will actually, or give them something else to do with their hands that will ultimately lead to, so it's kind of like a domino effect. So there are staging, questionnaires. You don't really even need a questionnaire, and there are different ways of helping people at different stages. And that's pretty well documented, and that's a very good, you talk about a standardized knowledge base, that would, I think, contribute to that. So yes to readiness to change. And then around the glossary, what you might want to do as you work towards a shared standard is to actually, all those who are leading in your own pockets of health coaching activities and self-management activities to all get together and decide what terms to define and have it a shared exercise, so that there's this beginning of collaboration as opposed to competition. I'd say that would be a good thing to do. On the standard side, here's what we're doing in America, which may or may not be easy to do probably not easy to do right now, but there are steps towards establishing a new profession or professional competency that are well-worn paths that have been particularly written about with alternative professions like acupuncturists and naturopaths. And so the way it comes about is that the educators and trainers are asked to step aside, and something called a job analysis is done, where you take a group of a dozen, 10, 15 practicing, experienced, in this case, health coaches. You put them together for 3 days with an expert facilitator, and they come out with a list of tasks that are the things the coach does. And then from there, they begin to sketch out what are the knowledge and skills that are needed to do those tasks. And then from there, what's the training and education process and the pre-existing health sciences background that you need in order to do that. So that's where one needs to get to eventually. And so in the US, we're actually raising the money through a nonprofit entity to fund that work. But we have thousands of practicing coaches, so it's not going to be hard for us to get them together and then do ultimately a survey of all of them to validate that. So when you don't have all of those coaches out there, then you really have to, again, come back to some collaborative approach where you kind of agree on where do we set the bar? And then there needs to be some way of measuring the bar. How do you oral tests of skills? How do you know whether you have baked a coach, as I say? How do you know whether they've got the skill they needed? And then how does that then translate into outcomes? How successful are they with different client groups? And then how do you feed that back into the skills training? So it's a long run, more like 10, 20-year iterative process where you set the bar and then you have some mechanism for continuing to raise it based on the evidence.
Thank you. Sue, should we're kind of broadening the conversation, which is great, and we'll kind of hear from all of our panelists and then kind of pick up some more questions.
That's really helpful because obviously people have always covered all the things. So I fear there's nothing left except for me to be controversial. So let me try that tack. A couple of things. First of all, based sort of on the second question about how do we know the patient is ready, and it made me reflect on something I'd been thinking about on my way here, which was this issue of, is this all about behavior change and people changing? And I sometimes think in the language that we write down, and I dare to think that perhaps some people came here because they thought this was a way in which they might change people to live less expensive and more useful lives. So one of the things that I would like to open up is a debate to the degree to which this is about behavior change, and whereas it used to be a neutral concept, is it still a neutral concept, or is it actually a weaselly thing that health professionals really wish they could get to grips with? The second thing, as I open it out, would be that I would challenge, I suppose, the audience to reflect on what Margaret's just said in a UK context. Do we want a new group, a new profession, or do we want these skills, if we can define them, spread around the whole NHS? But I just leave it at that. Sorry, it's my challenges to you, I'm afraid.
Fabulous, thank you very much.
I mean, I think for me that sparks the same thinking, actually. It seems like one of the conversations that the NHS needs to have is this a set of skills or approaches that clinicians who are already having contact with patients are using, or is it about a service that's set up on the side at some level? And I think there are pros and cons for both. I think some of the thinking around that probably needs to be economic as much as effectiveness. And I think that in responding to the point about when is someone ready, I think what I've been seeing consistently is it depends very much on whether the clinician is ready to actually take a different approach, and if they feel confident to be able to do that, particularly with view to the system that they're working in, if that makes sense. So I guess I'd challenge people to consider it not so much necessarily whether the patient is ready, because it's very much, there are plenty of standardized tools out there. The transtheoretical model's been around for a long, long time, 20 years at least, and people have been using it. But that hasn't necessarily led to people changing their conversations. And I think that's probably where we need to be focused.
Thank you. Alf.
Stimulating, isn't it? The glossary and the workforce. Hands up. I was going to start the glossary before this meeting and I didn't. So 10 out of 10 important, but I didn't get my action plan together, Penny, I'm sorry. A glossary is urgently needed because that defines the purpose. What is it we're trying to achieve? Yeah. And then when we've got the glossary in the right place and we know what we're inviting our workforce to achieve, we can then work with the workforce to invite them to develop those skills, as long as we've got a coherent measurement system alongside that. There is a national institute called the Quality Institute for Self-Management, Education and Training, Kismet, and Jim Phillips, who heads that organisation, is really keen on developing this glossary and also these quality assurance mechanisms alongside that. The other piece around readiness, it's really tempting when people who one might label as being in pre-contemplation or activation level 1, it's really tempting when they say to you, no, you just tell me what to do. It's really tempting to say, well, all right, why don't you go ahead and do so and so? I would say to you that we fail them if we do that. We fail them. We trap them in what one might call pre-contemplation or activation level 1, and we consign them to a life where they're not activated problem solvers. There are very specific skills that we can acquire. Empathy, I completely agree with you, is just so important in that place. Also some very specific skills. I have some ideas to share with you. I wonder what ideas you've got. Just kind of really, really, really simple tools that we can use to support people in that place. So that's me. Thank you, Robert.
Fabulous, thank you. I hope this is starting to help with some of the burning questions, but I know we have more, so shall we ask this table here, please, who are without number, but that's fine.
The table with no number. Gosh, and no microphone. Our main question was going to be that coaching or coaches question, and actually, do we end up segmenting individuals into whether they need a coach, not whether they need coaching, and is that really terribly person-centered? And if all of our clinicians were acting in a coaching capacity, would anyone think we ever needed separate health coaches? But you can continue to debate that. The other one was Penny said, I'm not sure if Rebecca is still here, because if she is, I'd love her to join in the debate, but I'm not sure she is. Penny talked about really coaching is really dangerous, and you shouldn't let it out, let it loose unless they're experienced clinicians. You didn't use the word dangerous, but you talked about risks to patients if you didn't use experienced clinicians. That's what you said. And Rebecca talked about training GP trainees. So I wonder if someone could just close that loop for me.
Thank you. And that picks up on a number of questions from lunchtime, as well as one via Twitter. Somebody mentioned that NHS Direct are rolling out or testing out health coaching as a method to be done remotely, which seems to cover a few steps removed. And a couple of people have asked about questions regarding quality assurance and safety and the evidence that would help us deploy this, partly from the right people. There's a question about selecting the right patients. And to feed on Johnny's last point, someone said, at what stage of professional development is it appropriate to start giving coaching skills? So we kind of bundle all those together. Who'd like to kick us off, kind of sharing some thoughts about that? Because you've all been involved in promoting this. Have you been doing it safely?
I feel I have to rise to Johnny's challenge there. I'm not sure I said exactly that there was a risk of training people who are less confident in their clinical skills in coaching. I would suggest that we had a spectrum of experience in our nurse practitioner groups, and some did not have very much experience. They weren't very confident, and they just found it more difficult to take on the skills, to apply them, and use them together with their clinical training. I mean, obviously, we all need to make sure that a patient is safe. But then having done that, you know, I think Sue and Alf very clearly said that someone with a long-term condition doesn't always come to us in a crisis. They might come in a crisis, but they also come when they're stable. They also come for an annual review. They also come because they're depressed, or they also come because they're a carer and they're not coping. And so therefore, we don't need either crisis management or unsafe management. There is a whole spectrum of different approaches that we can try and remember to use depending on where the patient is and where they are in terms of their condition, their lives, their mental health. I think we do this, but I don't think we're always aware that we actually flex our consultation style. And all I'm saying is that building on what we know, we can develop more skills around supporting patients make changes themselves. So I really don't think it's, if you give coaching, you're not really looking after the safety of your patient. You're always looking after the safety of your patient, and then, when it's appropriate, you can apply your health coaching skills. The second question was, to what level of experience should people go on a training course? And my hunch is, or I might be wrong, but my hunch is that actually it's probably more experience. It's probably a postgraduate training rather than an undergraduate training. I remember when I was training in general practice, which is actually quite recently, because I trained in public health first and then retrained as a GP, and I had fantastic training in consultation skills. It's actually remembering to use them that's the problem. I think it's more a postgraduate thing for both those reasons. I'm sure I don't know what my colleagues would think.
What you said there just reminds me that it's, I suspect, related to role, and also in a sense to the, you're describing a very sophisticated senior role where you have to flex around. But there are people who work in very, very important roles, health trainers, City and Guilds trained people for whom these would be bread and butter skills, but they're used in a very focused way, in a very specific way. And also, as we probably all should have, more supervision of how we behave and use these skills than we certainly have. So I think it's related to the role that the person is in, not necessarily to pre-post graduation. Just a thought.
Yeah, I think it's a really good point. And consistently from clinicians, there is a fear expressed of, if I become completely non-directive in the consultation, I'm going to miss some red flags. And that's the kind of topic that often comes into the conversation that we're having with people. And I think over time people start relaxing about some of that, because of course they will see those sort of red flags and that sort of stuff. But it's an immediate response that people have, and concern around risk is clear for them. I personally feel that what I've seen is that when someone feels competent in their role, no matter what the role is, then they're willing to try something new. And the question then becomes, when should you deliver that new thing? My personal experience also is that at an undergraduate level, there's so much medicine or so much nursing or so much other things that I'm meant to learn that actually it's good to be introduced to these concepts, but they don't necessarily flow through to the actual work I do with patients afterwards. So a top-up around some of those concepts could be potentially useful.
I want to reflect back on the conversation that was slightly being had by Twitter and slightly over lunchtime, but just picking up on that and see if other people can kind of add to it, which is a question about, given that what we're saying again and again is some fundamental problems with the medical model, you know, the biophysical model of understanding people's problems and addressing them, we're actually talking about the need for large numbers of people to unlearn what it means to be the professional that they've been trained to be. It's not just about getting a new skill and using it like a tool in your hand. You know, I've got a new ophthalmoscope, I'll use it. It's something more fundamental. I was really struck by the King's Fund blog about professional identity, which describes the need for doctors to be experts and specialists so that they can tell people the truth with real depth of knowledge. Right back at you, Andrew, wouldn't it be better if people didn't have to unlearn because they hadn't actually been trained into that mindset in the first place? Yeah. Might one turn this completely on its head and say, actually, because it's so much harder for people to unlearn, first-year medical students should have this as the foundation of the way in which they interact with the people they serve. Sue, what do you think?
I thought you were going to force Andrew to respond to that.
We originally agreed.
Well, I mean, some of the new curricula do start from fairly fundamental different premise about how people should behave. Problem-based undergraduate learning isn't specifically focused on this, but is focused on a different paradigm of your view of the skills that you will need as you go forward. So it's not a bad idea that this could be one of the things that is introduced early. It's a fundamental thing. It's about role, I think, although we don't talk enough about role, and health professionals don't think of things about role. So developing the role at an undergraduate level might be a very profound way to do the sort of thing you're talking about. But I don't know what other people think.
Alf?
I agree with you. I guess I would say that the biomedical model has led to the problem of long-term conditions. And if it's led to the problem of long-term conditions, we can't use the biomedical model to fix the problem it's created. We need to look beyond the biomedical model in the 21st century. I don't think we should ditch biomedicine. It's really, really important. It's really good when you have COPD to know how to use your inhalers, but we certainly need to augment it.
Thank you. Let's keep moving. Do you want to pick on table 3 next?
We had an interesting discussion. I think we all bought into the concept of self-management and people taking control of their lives. We weren't totally convinced that health coaching was the silver bullet. It was one of the techniques, but not necessarily the only technique. But we had also had a conversation about, do we need to force system change, or should we force this to become part of the core curriculum of all health professionals, echoing the last conversation. And in many ways, it's a bit of a chicken and egg debate, really, because actually if you change the core role of professionals, but you don't change the system, or the other way around, it doesn't work. So I think it's something about how we do both. But the other point which came up, which I thought was quite an important one, is we've conditioned our population into the medical dependency model. You've only got to look at casualty on a Saturday night, not that I ever do, but my children do, to realise we have created the doctor as the hero, the professionals. And if actually taking control of your lives and managing your own condition in partnership with professionals is what we're looking for, somehow we've got to try to encourage the public to come with us on that journey.
Thank you. It's interesting. We're really broadening the debate now. Can we get some from table 1, some from table 6? Keep moods. Feel free. So is there anything? So we'll start with table 6. Thank you. So what things came up for you?
We had an interesting conversation as well. One of the issues was the role of an expert patient or a patient in coaching, and also the role of a healthcare assistant to be a healthcare coach. A person who's obese or a person who smokes doesn't have to have a doctor or a nurse to be as an expert to motivate to do something about it. There's nothing wrong in using someone from the community, like a healthcare assistant or a healthcare or a patient, an expert patient. We do have expert patient programs as well. And I just wonder whether there is a role for having healthcare assistants being trained up, because there are colleges that do these courses, against the City and Guilds course, kind of a thing, and using them and utilizing them in a team to become coaches in the practice.
Lovely. Thank you. And table 1, do you have sort of things to add from your conversation?
This is Simon speaking from the College of Medicine. One of the questions, in fact, follows on from the previous one, is that we've heard very much today about doctors and health professionals being the providers of this service, and I thought we were here to talk about the other way around, in that the person who sometimes calls a patient has clearly a co-partnership, at least co-creation role here. And one question would be, what is the recovery plan here? Do we just create more dependency on health deliverers to deliver the coaching, or can we graduate them into a culture or a network of people who can support them, given that people do talk to each other? So to roll out the coaching into the health trainers and into the wider community seems to be at least one way of bridging this.
Lovely. Thank you very much. So, panel, from that buffet of questions and comments and observations, we've got 5 minutes left. So, who wants to pick up one of those themes? Please, yeah.
I completely agree that we should be focusing more as well on community-based assets. What we know from an awful lot of behaviour change theory and evidence is that it's sometimes difficult to maintain change after about a year. So people might go through a kind of a coaching program, and if they go into a kind of a vacuum, then sometimes the kind of confidence and skills can erode. So I think alongside this, building community assets is really incredibly important. Supporting the community to build its own assets.
Thank you. And Margaret had a thing as well.
Well, I'd like to come back to, because I got the question around, we have a need, and you're presenting health coaching as the answer, and it doesn't feel that that's really all the answer that there is. And so I'd like to just put back on the table the notion that, and I'm a biologist, so I'm back to the thriving mode, that there are some fundamental principles about how humans thrive, whether it's in whatever relationship, in whatever setting, at the workplace, in a doctor's visit with a nurse. And those are the fundamentals that we want coaches to learn, that we want healthcare providers to learn, that 20 years from now will be integrated into becoming a nurse, becoming a doctor. It'll become, these are just universal principles. This is what, and that the very best coaches will be able to work with the most challenging clients. The people who are, potentially going to bariatric surgery. So you're not going to take a brand new coach with a 4-day workshop and have them be successful with someone with chronic, with all the multiple. So there's got to be this kind of continuum of these core principles that are layered, from being a new student to being a mature coach who gets the catastrophic cases and is successful 65% of the time or something like that. So I think if we can get to this place of these are principles where the evidence is pretty clear, and that's what we want to bring in universally, and then there will be various levels of mastery of those, from the consumer coaching themselves to the most, masterful coach.
Thank you very much. We have 2 minutes left. Would anyone like to address any of the themes there, or kind of say something, there's an elephant in the room we haven't touched on yet?
Can I just address the issue around coaching and patient activation and say that we all recognise that that's absolutely fundamentally important too, and that patient activation, clinician activation are two sides of the same coin. But it was just a conscious decision that we could only do a certain amount in today. Hence, we are focusing on the left-hand wall of the house rather than the whole house. And one of the problems and one of the difficulties is in integrating this is when we go back to our own organisation, we're enthused, is how to make sure that we not only do the health coaching or we think about what skills we need to activate our patients, but also what systems we need and how we can work with patients. So we take that back, bearing that in mind. I mean, Alf is the person who knows more about this because through Co-Creating Health, he actually tried to integrate those, integrate those three things together. I'm an idealist, and I would hope that we could all do this in tandem and together. But I sort of think in the real world, it's actually really difficult to do to get those aligned. And particularly now with the health service as it is and the reforms and things, to actually create a system change, to activate patients, and to put this health training all together in tandem. It may be difficult. So I wonder whether it's just good to start at one and grow it, or to you know, what can you do that's practical and feasible and achievable that will make a difference? I don't know, Alf and Sue.
Can I just come in? I'd say build a house first. You know, I've been involved in £20 million worth of change programs, trying to embed this into our current systems. The current system is the wrong system. Build the house first, change the delivery system, then get the skills in. It's pretty clear, isn't it?
About that is it switches the focus entirely away from the skills and the mindset change that we've been talking about to whatever we mean by culture and system change.
Yes. I'm going to call time. I'm really sorry. It has deliberately been a packed day, but one of the prices we pay is that we can't enjoy things for as long and as much and deeply as we might like to. I'm going to ask our panel to finish with one challenging question, which has been pressing on my mind. It was asked by a few people on here. We haven't touched on it yet. Really practical one, actually, to end with. What's the shortest amount of time investment it would take to train an experienced healthcare professional to do this well enough? And if you can do it, just a single word answer with a number of days, that would be fabulous. And Alf, will start with you.
Bare minimum 2 days.
Thank
Bare
you.
minimum.
Andrew?
2 days minimum.
2 days. Sue?
Well, I can't answer it because I don't know exactly what it is in terms of definition, and I don't know what the role of the person who is needing to be trained.
Thank you.
My experience is that it takes 3 months, not necessarily a lots of workshop, but 3 months from start to finish to really change the mindset at minimum.
Thank you. Penny?
2 days and lots of reminders.